Hi, my name is Joel Mousse. I am an anesthesiology resident in the Department of Anesthesiology at Vanderbilt University School of Medicine. Today we're going to discuss EKGs, or electrocardiograms, and discuss normal electrocardiograms and abnormal ones, and this is a two-part lecture series. The goals and objectives of this presentation are to define a normal and understand how it relates to the beating heart, to monitor for both issues that we worry about during the provision of anesthesia. We're also going to learn how to distinguish between a normal and an abnormal electrocardiogram, and also develop a basic understanding of what to do about abnormal rhythms or abnormal electrocardiograms. The beating of the heart is mediated by electrical impulses, the beginnings of which start at the sinoatrial node or the SA node in the right atrium. This electrical impulse leads to atrial depolarization and the generation of what is known as a P wave on the electrocardiogram. This electrical signal traverses down into the atrioventricular node and down the interventricular septum between the left and the right ventricle, leading to the contraction of both the right and the left ventricle. This ventricular depolarization is represented as a QRS complex on the electrocardiogram. Following ventricular depolarization, ventricular repolarization commences, and this is manifested as a positive deflection on the electrocardiogram known as the T wave. In short, the beating heart generates a P, QRS, and a T complex on the electrocardiogram with every beat. The electrocardiogram is generated by placement of various leads to monitor the PQRS-T complex every time the heart beats. There are approximately 9 leads that are used for the generation of an electrocardiogram. 3 limb leads, AVF, AVR, and AVR, as well as precordial leads V1 through V6, placed mostly on the left chest. The electrical signal generated by the heart in general travels in this direction in the chest. These leads perceive this electrical signal based on the travel of the PQRS complex as the heart beats every time. As you will see later on, this PQRS-T complex is seen differently based on which lead is examined on the 12-lead electrocardiogram. Below is a 12-lead electrocardiogram. This is generated once all the leads are placed and the electrocardiogram is ran. As you will note, there are 12 leads represented here on the electrocardiogram. Lead 1, 2, 3, AVR, AVL, and AVF, and leads V1 through V6. In the operating room, we almost always just monitor 2 leads, lead 2 and lead V5, with lead 2 being sensitive for rate and rhythm, and lead V5 being sensitive for ischemia. We'll discuss this as we proceed with this whole lecture. You may also notice that the PQRST complex varies depending on which lead you are looking at. For example, lead 2 has a general positive deflection in its complex compared to lead AVR. As I mentioned before, the leads are like electrical cameras measuring the PQRST complex as it travels down in this general direction in the heart. And so it is no surprise, therefore, that most of the deflections in AVR are negative or moving away from that electrical camera AVR. This is one of the few fundamental principles in electrocardiogram interpretation. Once an electrocardiogram is obtained, it is important to start interpreting it. Each electrocardiogram is usually printed on graphing paper, such as the one shown below. This makes it easy to start calculating the rate, which is the first thing you should interpret on an electrocardiogram. Each large box on an electrocardiogram represents 0.2 seconds, and each large box is divided into 5 small boxes, each representing 0.04 seconds in time. The easiest way to determine the rate on an electrocardiogram is to determine how many large boxes are between two QRS complexes, such as the ones pictured here, where we have approximately 4 boxes between the two QRS complexes. Dividing 300 by the number of large boxes between QRS complexes gives us a rate of approximately 75 for this electrocardiogram. You may notice that the calculated exact rate is 77 beats per minute, which is close to our interpretation based on the number of boxes that is between the QRS complexes. The next thing to do on an electrocardiogram is to determine whether it is in normal sinus rhythm. As we discussed before, the electrical impulses in the beating heart originate in the sinoatrial node. This is what designates a QRS complex as originating in the sinus, or an electrocardiogram being in normal sinus rhythm. When we examine lead 2, we notice that there is a P wave preceding each QRS complex. This means for the duration that we examine this electrocardiogram, this patient was in normal sinus rhythm, meaning his electrical impulses initiated in the sinoatrial node and traversed through the heart in a normal fashion, generating a normal electrocardiogram. So this patient is in normal sinus rhythm at 77 beats per minute. As you may have noticed from the beginning of the presentation, the PQRST complex has intervals that are normal, or that would designate an electrocardiogram as normal. For example, the P wave is not supposed to last longer than 0.12 seconds. With each small box on this graphing paper being equal to 0.04 seconds, a P wave should last no longer than 0.12 seconds. The distance between a P wave and the R wave should also not be longer than 0.2 seconds, and this is 5 small boxes. The QRS should also not last any longer than 0.12 seconds, which is 3 boxes, or the 3 small boxes, and the QT, or the distance between the Q and the T, should also not last any longer than 0.44 seconds, which is 11 small boxes. These are all intervals that should be interpreted on every electrocardiogram that is obtained for a patient. Let's proceed with the discussion of some abnormalities that you may discover while caring for your patients under anesthesia while monitoring their electrocardiogram. Most patients will manifest normal sinus rhythm throughout the majority of their case. They will also exhibit normal ST segments, or the segments between the S and the T on the PQRST complex. Some patients, especially when stressed during surgery, will start to have or manifest these ST segment depressions. This indicates that there's a mismatch in the delivery of the oxygen to the heart relative to its demand. This may be due to underlying coronary artery disease that is previously undiagnosed, or an incomplete blockage in the arteries that supply the heart. This is most often seen in lead V5, as we discussed earlier, as it is the most sensitive lead for detecting this coronary ischemia during anesthesia. ST depression, if left untreated, can continue into the death of heart muscle. Here is an example of a 12-lead electrocardiogram in a patient who is experiencing ST depression. Here in lead 1, we see prominent ST depression as well as an AVL, and this territory is the lateral wall of the heart. The patient also has ST depression in V3, V4, V5, and V6. This indicates that this patient also has ischemia in the anterior portion of their heart. Here's another example of a 12-lead electrocardiogram in a patient who is experiencing ST depression. If we examine leads 2, 3, and AVF, we can see prominent ST depression. This indicates that this patient has ischemia in the inferior portion of their heart. Leads V4, V5, and V6 are also manifesting ST depression, indicating that this patient is experiencing ischemia in the anterior portion of their heart. Patients who manifest ST depression should initially be placed on 100% oxygen to maximize oxygen delivery to the cardiac muscles that are now experiencing ischemia. Decreasing oxygen demand by the heart by slowing it down with a drug such as a beta blocker, such as metoprolol, at a dose of 5 mg IV at a time, is also indicated. Caution should be exercised when providing or administering metoprolol to patients under general anesthesia, as they may not tolerate its cardiodepressive effects. Patients who have a heart rate less than 60 or a systolic blood pressure less than 100 should not receive any metoprolol, as this could cause cardiovascular collapse. Increasing blood supply to the heart muscle by treating anemia or increasing blood flow to the heart by dilating coronary artery vessels can also be effective in treating this coronary artery ischemia. Nitroglycerin can be administered sublingually at a dose of 0.3 milligrams, but can also be given intravenously at a continuous infusion at 5 micrograms per minute. Aspirin at 325 milligrams should be administered either by mouth or rectally if possible. Let's continue our discussion of abnormal EKGs with ST elevation. ST elevation and ST depression are both similar in that both indicate that the heart is experiencing ischemia. As discussed previously, the ST segments pictured here are depressed in ST depression. However, in ST elevation, they are elevated above the baseline, as pictured here on these two electrocardiogram tracings. ST elevation indicates blockage to one or more of the arteries that supply the heart. As with ST depression, placing the patient on 100% oxygen maximizes how much oxygen we can deliver to this heart that is experiencing ischemia. Decreasing the heart's demand for oxygen by slowing it down with a drug such as a beta blocker is also indicated for treatment of ST elevation as with ST depression. As discussed previously, dosing metoprolol at 5 mg IV should proceed with caution, as patients who are under general anesthesia may not tolerate its cardiodepressive effects. Patients whose heart rates are already less than 60 or whose systolic blood pressure is less than 100 should not receive any metoprolol, as it could lead to cardiovascular collapse. As with ST depression, increasing blood supply to the heart, either by dilating coronary artery vessels with nitroglycerin or by correcting anemia. This correction of anemia increases how much oxygen will be delivered to the heart by increasing how much hemoglobin is in the blood to carry this oxygen. Patients with ST elevation should also receive aspirin at a dose of 325 milligrams, either by mouth or rectally when possible. Consultation should be sought with a cardiologist or a cardiac surgeon to alleviate this blockage in the coronary arteries. Here is an example of a 12-lead electrocardiogram of a patient who is experiencing ST elevation. As you can see here, this patient is experiencing ST elevation in leads 2, 3, and AVF, indicating that the artery that supplies the inferior portion of the heart is blocked. If you notice, this patient also has a severe bradycardia with a heart rate of 41, and this patient would therefore not be a candidate for treatment with metoprolol, as this could slow his heart rate further and lead to cardiovascular collapse. Here is another example of a 12-lead electrocardiogram of a patient who is experiencing ST elevation. Pictured here, you can see this patient also has ST elevation in leads 2, 3, and AVF, indicating that this patient also has ischemia in the inferior portion of his heart. Q waves, pictured here, are rarely seen in a normal electrocardiogram, and they represent an already completed myocardial infarction or heart attack. Q waves may be an indicator that a patient may have reduced heart function due to a previous myocardial infarction and may have signs of heart failure such as edema, shortness of breath, especially when laying flat, and decreased exercise tolerance. These patients have an increased risk of experiencing more myocardial infarction, especially if they have not been medically managed to reduce this risk. Here is an example of a 12-lead electrocardiogram of a patient with Q waves. If we examine leads 3 and AVF, we see that this patient has already infarcted his inferior portion of his heart. Further examination of this patient's electrocardiogram demonstrates that this patient also has infarction in V1, V2, V3, and V4. This patient has likely infarcted multiple portions of his heart, and this patient would likely have congestive heart failure or reduced heart function. Here's an example of another 12-lead electrocardiogram of a patient who has a remote infarction, meaning an infarction that has happened in the past already, that is demonstrable on his 12-lead electrocardiogram. If we examine leads V1, V2, and V3, there are clearly visible Q waves indicating that this patient has infarcted the anterior portion of his heart. This patient may have decreased cardiac function or congestive heart failure due to this infarction or death of cardiac muscle. To summarize, over the course of this module, we've come to define how a normal electrocardiogram is generated and how it relates to the beating heart. We've also learned how to obtain this electrocardiogram and use it to monitor patients undergoing anesthesia for both rhythm and ischemic abnormalities. In this module, which is part 1 of a 2-part module, we've learned to distinguish between a normal electrocardiogram and an electrocardiogram that indicates either current or remote ischemia. We have discussed ST depression, ST elevation, and Q waves. Part 2, which builds on what we have discussed in this module, will discuss some rhythm abnormalities as well as other physiological abnormalities that may be detected on electrocardiograms in patients who may be undergoing general anesthesia.